Our next speaker is Yasmeen Selim. She's from pediatric department, assistant lecturer.
First of all, I would like to thank my very dear professor, Dr. Amali Bishdawi, for giving me this chance today. Our patient is a female patient, 12 years old. She's the second child of a consanguineous marriage. The condition started at the age of 2 months when the mother noticed pallor. CBC was done revealing microcytic hypochromic anemia. She was diagnosed as iron deficiency anemia and prescribed oral iron for 6 months. From the age of 2 months until the age of 5 years, she was following with the doctor in his private clinic. She was not compliant to her follow-up visits, was on oral iron therapy on and off, but the anemia was not improving and she did not receive any blood transfusion during that period. Starting at the age of 5 years, the mother noticed severe pallor and easy fatigability, no jaundice or dark urine. She sought medical advice at that time at our hematology outpatient clinic. Her initial investigations revealed severe microcytic hypochromic anemia. Hemoglobin was 6.4 and she received her first blood transfusion. MCV was 58.9 and MCH was 18. Her reticulocytic count was very low, 0.1, and serum iron was high. Hemoglobin electrophoresis was done and HPLC, both were normal. Bone marrow aspirate with iron stain was done, which revealed marked erythroid hyperplasia and increased sideroblasts 80% with 65% trinket sideroblasts. And our patient was diagnosed as a case of sideroblastic anemia. Since then, our patient was transfusion dependent every 3 to 4 weeks. She was iron overloaded on deferrizirox 20 mg per kg per day. At the age of 10 years, she came to our BMT counseling clinic and was counseled for BMT if she had an HLA-matched sibling. This is her family pedigree. She is the second child. She has a youngest sister, which is also diagnosed as sideroblastic anemia. During examination of the child, we noticed that she had an abnormal gait, waggling gait, Gower's sign, hypotonia and hyporeflexia of both lower limbs and lumbar lordosis. Reviewing the patient's developmental history, she had delayed speech and delayed walking. The mother was attributing this abnormal gait and developmental delay to the anemia, and so she did not seek any medical advice for that. Investigations done, EMG and nerve conduction revealed myopathic changes. CK and lactate were high. We have myopathy, high lactate, and sideroblastic anemia. We tried to find a syndrome that links all three. When we revised the classification of sideroblastic anemias, it's classified into congenital and acquired, and among the congenital causes was the Melassa syndrome, myopathy, lactic acidosis, and sideroblastic anemia. Our patient did bone marrow transplantation with the following conditioning regimen: busulfan, cyclophosphamide, and ATG. The stem cell source was peripheral blood stem cells. Her donor was an HLA-matched sister. GVHD prophylaxis, cyclosporin was given. She was engrafted at day plus 21, number of isolation days 28, duration of hospital stay 54 days. Major complications after BMT: worsening of weakness of both upper and lower limbs happened, which was proximal more than distal. We did another EMG and nerve conduction, which revealed widespread muscle disease, likely dystrophic. CK was repeated, which was very high. We were between acute GVHD versus drug-induced myopathic changes. We started steroids at 2 mg per kg per day. The weakness returned to baseline, then followed by gradual withdrawal of steroids over 4 months. Her chimerism all through she was in a state of mixed chimerism. Hematological indices improved. Pre-transplantation, her hemoglobin was 5, and after transplantation, her hemoglobin reached 13.5, and MCV improved. Melassa is a rare disorder of oxidative phosphorylation and iron metabolism. It's a mitochondrial disease, autosomal recessive, pattern of inheritance. The reported gene mutations: POS1 gene mutation, which is pseudouridylate synthase, responsible for post-transcriptional modification of cytoplasmic and mitochondrial transfer RNAs. The other gene responsible, the YARS2 gene, responsible for mitochondrial tyrosine transfer RNA synthetase, with some mitochondrial DNA mutations. After bone marrow transplantation, the myopathy did not improve above the baseline. We could not compare this to other cases in literature because there were very few reported cases in literature, and the diagnosed cases did not undergo bone marrow transplantation. Two reported cases, one with Melassa syndrome due to POS1 gene mutation, reported in a Turkish child. Another one was reported in a Lebanese child. Thank you.